Good evening and welcome to week 2 of Respiratory 241. It's your instructor Tim again, and happy to be here. Been a bit of a hectic day at the hospital, so just getting up and rolling here, but happy to be here. Today is September 11th, 2017, 9/11. Need I say any more than the solemnness of this day, and I'm sure as some of these days in history we've experienced, everybody knows what, when, where they were doing when we either saw or heard or whatever that day. But welcome you all, and appreciate you being here. It's also opening night of Monday Night Football, so if you're a Broncos fan or Chargers fan or Saints or whoever is playing today, thanks for joining me, or in the recording later because you're watching the game. So having said that, we're going to jump right into what we've got. We've got a lot to cover once again tonight. Like I said, mechanical ventilation's got a lot to it, and we need to cover everything. If you do have questions, concerns, comments, please get a hold of me. Some of you already have, which I appreciate you doing that, reaching out. I love to help. I love to be involved, and I want you to do well and understand it. So just a couple of things. Just remember in your discussion posts, the ABG, for the most part, everybody did well with the interpretation ABG. You're going to see some more of that. So make sure you're interpreting your ABGs okay. Make sure your length is appropriate, at least 150 words, and that you are using your references in those discussion posts. That goes with assignments as well. A couple of the assignment submissions were not in APA format. Please do so. It's something that you need to do, something you need to know as a college student. So if you don't, there's lots of stuff online to help you. Word, and there's apps. Microsoft Word has some resources, etc. So take advantage of that. And also your length, make sure that it's of proper words. I will deduct if it's not long enough, and I do a hasty count of your assignments, so keep that in mind. The quiz, for the most part, I thought went okay. If you didn't do great on it, remember to review, and it's kind of redundant that I say that, but I really mean it, to please review what you missed and make sure you understand it. You most likely will see that question again on your final. So keep that in mind. Your ventilator terms, I kind of gave you a list last week. Respiratory mechanics, vent types, things of that nature. Make sure you're staying up on that. As far as of what types of breaths, what modes, breath types, how we trigger it, all of that. Please review that constantly. Make sure that you understand what your modes are, what your breath types are, and how we trigger those breaths and how we set those breaths. Because if we don't have that as a good foundation from last week, then it's real easy to get lost in these subsequent weeks. So having said that, let's forge ahead, and let's go from there. Just a quick overrun of ABG interpretation. For the most part, like I said, everybody did pretty good. Just a quick rundown of what I like to do when I have a ABG in front of me is I first establish the pH. If it's below 7.35, I know it's acidic. If it's above, I know it's alkalotic. If it's above 7.45, I know it's alkalotic. I then look at the CO2 to help me determine, is respiratory involved? Is it elevated? Is it normal, or is it decreased? I then look at the bicarb. That helps me determine, are we compensating or uncompensating? And then lastly, I look at my oxygenation. That's just quick, down and dirty. If you need further insight or any more tricks for ABG interpretation, please let me know, and I'll be happy to help you. And then here's just a quick down and dirty. And these are all over, whatever search engine you want to use and take a look at. But a nice quick resource here of ABG interpretation, and if you have any trouble with that, let me know. So this week we're going to cover chapters 4, 5, and 6. There'll be a really nice discussion concerning that, and then also an assignment tied to that. And it's good stuff. Keep in mind that also in the media section of your Canvas course, keep in mind that there's some really nice resources in there. There's some videos, etc., some tutorials, and I know we're all busy. I know we all don't have a lot of time, but please take advantage of those opportunities for learning. They will help and guide you on whatever the discussion is for the week. So if you have not, take a look at that. And if we have time tonight at the end, I'll jump into Canvas and show you some of that stuff if you haven't seen it before. So let me okay, so if you remember last week, we talked about negative in-story ventilation. We looked at positive pressure ventilation. We talked about the different parts of ventilation. We talked about the different parts of ventilators, I should say. We discussed the breath delivery unit, the user interface, the circuit, different types of circuits, the single limb, the dual limb. We talked about ventilator terms, such as tidal volume, flow, IE ratio, I time, peak pressures, mean airway pressure, things of that nature, PEEP. So make sure that you're understanding all that. We also talked about some pressures in regard to, ventilation and internal and external respiration, and how the mechanics of ventilation happen in ourselves with the diaphragm deflecting down. Looked at alveolar pressure, transpleural pressure, transairway pressure, things of that nature. So make sure you're aware of that, and the little waveforms that I showed you that shows you some of those pressure deflections and their ranges. You certainly will be quizzed on that again in coming assessments. So make sure that you're understanding those. If not, once again, let me know and let me help you. So we talked about, like I say, establish kind of an opening to the vents and mechanics of that. So now we want to talk about let's talk about now this week, let's talk about establishing the need for mechanical ventilation. There's lots of considerations that we need to consider before we place someone on mechanical ventilation. It oftentimes is something just as simple as the patient is in ventilatory failure, whether it's hypoxic or hypercarbic respiratory failure, but oftentimes it goes deeper to that. Is it going to improve their quality of life? Is it going to lower their mortality rate? Is it something that they want? Is it something that the family wants? Is it supported when we make these decisions, it should be supported by evidence-based criteria, meaning that that's been studied, that we've looked at it, and we're not saying, oh, I think this was a good idea. We know the data that if we place a breathing tube in this patient, that they're going to have a good outcome based on their diagnosis. As far as the physiologically, we want to support or manipulate our pulmonary gas exchange, increase those volumes, and increase their work of breathing. Those are, if any of those or any or all are out of whack, that's certainly a criteria of why we want to place someone on mechanical ventilation. So we have these considerations. If we do not have effective gas exchange, that they are in respiratory failure, we have poor volumes because of either said respiratory failure or some other condition, whether it be a trauma or things of that nature, or they have increased work of breathing because they're exhausted from the respiratory failure. All those things we can mitigate with our ventilator. So the objectives, that we can reverse the respiratory failure, we can reverse the respiratory distress, the hypoxemia, and you can look on down there that if we need to sedate them and protect their airway, that they're fatigued. We want to rest the heart. So those are certainly our objectives. And what we need to do is, before we do that, is we need to recognize those that are in distress. And this is where some of your discussion and your assignment for this coming week is going to go into is the signs of respiratory failure and recognizing and acting upon those folks that are in failure or in distress. So we can determine their LOC, we can see what they look like, kind of our view from the door, and then we have our vital signs, their rates, their blood pressure. We can look at their pulse oximeter. If we do have acute respiratory failure, the inability to maintain oxygen and CO2 and pH at acceptable levels. So if it's below the range under the normal conditions, that we have greater than 50 CO2 and it is rising, and we have a falling pH of 7.25 or lower and it's dropping, then that's criteria for that we fall into that definition of acute respiratory failure. We have two forms, as I mentioned earlier. We have hypoxemic respiratory failure. We have tissue hypoxia, and that can be any number of reasons. I'll put some posts in that talk about some reasons. I also have a post about dependent lung I have written, I'll share with you. We talk about hypoxic versus hypoxemic respiratory failure and some of those causes. But these are just some of the ways that we can hypoventilate. We're old, we have not adequate oxygen, diffusion defects, right to left shunting, and all these things are certainly things that you've covered in lower classes. I remember covering some of these back in when I taught Respiratory 121. So the other style is hypercapnic. So we have dealing with the oxygen side of respiratory failure. We can also have hypercapnic, or dealing with the CO2 end of it, where we're not ventilating enough. It's real easy to oxygenate properly and have a nice saturation, because the lungs are quite efficient and have lots of surface area to bring that oxygen in and diffuse it across the alveolar membrane. The other piece of that is, are we ventilating? Are we moving enough gas in and out to get rid of all the CO2? And that's where oftentimes we'll have an issue. And so if we have increased CO2, we call that hypercapnic respiratory failure, when the patient cannot achieve adequate ventilation to maintain a normal CO2. And so there are several issues that can be controlled by that, but we have the central nervous system disorders, neuromuscular, and then decreased disorders that increase the work of breathing. So recognizing it, mild to moderate, are they breathing fast? Are they short of breath? They pell? Is their heart beating fast? Things of that nature. And then the severe, where we're tachypnic, we're have increased dyspnea, now we're cyanotic. They could be sleepy, confused, loss of consciousness, could be bradycardic, have low blood pressure if we have prolonged or severe hypoxemia. On the flip side, work recognizing hypercapnia. A lot of the same, but really a dead giveaway for hypercapnia respiratory failure is the confusion. I often refer to the patient being drunken on CO2. They're confused, they stumble, mumble, they almost act like they're inebriated or drunk. They can have high hallucinations, they can convulse, loss of consciousness, they'll stop breathing. But the early signs are as that increases, they'll start to act drunk. Prior to that, when they have when we begin to have increased CO2 and hypoxic patients, they tend to get really jittery. You'll see a really jittery, almost spun up type of patient. And it's something that once you see it a couple of times, watch for it in your clinical times. Have your preceptor point that out if you have someone going into respiratory failure. They'll get really anxious and really jittery before you start to see the headache, the drowsiness, and the drunkenness, so to speak. So successful outcomes, if we use oxygen, we maintain that airway, and we can monitor them and use an arterial gas and get that early to help force or help us through our decision tree. So here's a really nice table of physiologic measurements where a normal range is and then what a critical value is. The thing I'll ask you to memorize this chart is these same numbers that we're going to look at are numbers that we're going to look at when we want to take someone off the ventilator and wean them off. We're going to look at these same number ranges that might have gotten them on. Now we're going to look at numbers to get them off. And so, our MIPS of 50 to 100 is what we're looking for as criteria to take them off the vent. Our vital capacity of 65 to 75 milliliters per kilo. Our tidal volume of 5 to 8. Our normal respiratory frequency. Our FEV1, which is a maneuver our vent can do, which is the negative force within the first our force expiratory volume within the first second should be 50 to 60 milliliters per kilo. And then our peak flow. All those numbers we can kind of derive from being on the ventilator, and those modern ventilators will give us all this information. We're a little limited if they're not on some sort of device that we can get these numbers from prior to them to know it's a critical value. But I urge you to get to know this chart. This is information that you'll use throughout your entire career as a respiratory therapist. So learn it and memorize it early because you'll use it. So the other physiological measurements is we're going to obviously look at the PaCO2 or the partial pressure of carbon dioxide in the arteries, and think to yourself, do I know the normal ranges of what CO2 is? Do I know what the normal ranges of PaO2 are? What's the normal range of pulse oximeter saturation or SpO2? And then the content of oxygen. If I don't understand content, do I need to look that up? And what's that normal range? What about the AA gradient and the PF ratio, those last two numbers? So all of those are important that we understand as respiratory therapists. And again, this is criteria to get people on, and then down the road to take them off the vent, that we understand these numbers. So 35 to for normal CO2 ranges of 35 to 45 for our CO2 range. Looking at PaO2, where I'm at Utah, we go 60 to 80 because we're at altitude. If you're at sea level, certainly that's going to skew up a little bit into the 80 to 100 range. So that's something that we need to consider. Sorry about that. My headphone was acting up there. So I think I got it going there. I got a headphone with the mic on it. Just making sure it was actually working there. Excuse me for the delay there. So we talk about CO2 and our oxygen, our saturation, anything above 88. Oxygen content is a content of oxygen, and that's accounting for our hemoglobin. Because we know if we have low hemoglobin, it doesn't matter if we're sat in 100% if we have low hemoglobin. And then I talked to you about a post when I post about hypoxemia versus hypoxemic. Our PaO2 to PaO2 or our AA gradient, certainly a lower number is better for that. And then our PF ratio, I'll also present a discussion for you this mod that's going to talk about PF ratio as well, and how we can diagnose acute lung injury. So a higher PF ratio is more beneficial. Specific treatments for dealing with hypoxemia is we can increase our oxygen. We can increase our mean airway pressure with PEEP or our breath timing. We can descend to lower altitudes if we have altitude issues. Diffusion defect, because we have inflammation on the alveoli, we can certainly consider steroids. Criteria for mechanical ventilation: not breathing, ventilatory failure, impending ventilatory failure, and then refractory hypoxemia, where we have given them increased oxygen, things of that nature, and it just doesn't work. And I certainly had that happen to me in the ICU today. Had a patient that was on 6 to 8 liter oximizer, kind of a pseudo high flow nasal cannula, doing fine, and all of a sudden I could not oxygenate her. Tried different lung positionings, had her cough, etc. Got a stat chest film, and she had lung collapse, probably from mucus plugging, and so we opted to provide ventilation to her today, and hopefully in the next 24 to 36 hours we can get those secretions out of there. We might have to bronch her, but certainly expect a good outcome with her once we get that out of there and we can get the tube back out. So these are possible alternatives to invasive. Is we can try BiPAP. We consider what we're up against as far as ethical considerations and positioning, and I tried all the above today, and it just wasn't flying. So that's the decision tree we went through. So indications for non-invasive: if they are breathing, they are showing some work, but not advanced work that we still have if we have an opportunity that we can get them turned around where they are still breathing, that they don't have issues with nausea, things of that nature. They have some accessory muscle use, they're working hard. Pulmonary edema certainly is helpful. Reasons that we'd want to go from non-invasive to invasive at that point is excessive respiratory rate. We lose their impaired mental status. We have cardiogenic shock. We have respiratory arrest. We can't oxygenate them with that device. So if they do fail on non-invasive, then this would be some of the criteria we're going to look at. I will say that as I'm jumping over to our next group of slides, I am always really impressed with how well non-invasive or BiPAP supports life. I've seen patients where they've been on continuous BiPAP, and where the patient's been on continuous BiPAP, And the families decided that they want to discontinue support on the patient and put them on comfort care. And they've been on the same BiPAP settings for several days, and the doctor writes the order, and we take them off of BiPAP, and I've seen them pass away in as little as 5 to 10 minutes. That just tells me of how well these modern BiPAP devices can support life. What also it tells me is when I have a patient that fails on BiPAP, they are really sick. If I can't oxygenate them or I can't get on top of their CO2s anymore in non-invasive ventilation, that tells me that I have a really sick patient if they're failing on that excellent technology. So really respect if someone's failing on BiPAP, that we need to intervene early and effectively to get them turned around with mechanical ventilation. So certainly please keep that in mind when we're managing our patients on BiPAP. So we've talked a little bit about, and I understand that we've gone over this fairly quick, but I do want to cover everything. We talked about the indications in the first chapter 4, the indications of mechanical ventilation. Now we're going to talk about, we've made that decision, we've tried non-invasive, and it hasn't worked, or the patient's failed on non-invasive. So now we've decided to place them on the ventilator, so we're going to go ahead and intubate that patient. And put them on the ventilator. And once we've made that decision, we need to decide what our strategy is, what vent we're going to use, what mode we're going to use. So now let's talk about that. So again, we're just going to briefly talk about non-invasive. We usually use a face mask or nasal mask. We don't even really carry nasal masks anymore at our hospital. We either use a full face mask, which goes over the mouth and nose, or we use a total face mask, which looks kind of like the firefighter mask is what we call it, where it goes over the entire face. We can use CPAP on that, just one pressure, constant positive airway pressure, or we can use two pressures like a BiPAP, and then it becomes a non-invasive ventilator. You've got to have two pressures there to create that gradient to ventilate a patient. Patients don't blow CO2 off via CPAP. It doesn't ventilate. All that does is inflate the alveoli, recruit up the lung. It helps with oxygenation, certainly. So CPAP has its place, but typically if we have someone that's hypercapnic respiratory failure, we want to provide something to them that's a pressure gradient so we can try and blow that CO2 down. The advantage and disadvantages. The greatest advantages is we don't have to heavy sedate those. The patient still participates, and we don't cause VAPs and things of that nature. The disadvantages are we can have skin pressure sores. Patients don't tolerate it if they're claustrophobic. We can have gastric distension. They can fill up the belly with air, and then they want to vomit, things of that nature. People can have irritating eyes. Leaks can cause it. They don't sleep well, on and on and on. So there are pros and cons to everything. I like to explain that to my patients as I'm initiating it. I also like to hand them the mask and have them put it up to their face so they know what it feels like. So when we start thinking about putting someone on the vent, you know, we can do a couple of different strategies. The techs want you to first know about the full ventilatory support, where we are going to set up our rate, our tidal volume, and we have a preset volume or pressure to meet that adequate tidal volume. And we're going to put them into assist control, CMV AC, either in volume or pressure control, and we're going to do everything for them. And so we're going to dial in a rate that's greater than 8 a minute versus partial ventilatory support. We're just giving them a little bit of a backup rate there, but we're expecting them to do all the breath initiation there and participate in the work of breathing. So when we talk about breath delivery and modes of ventilation, the type of breath, whether it's mandatory, is it spontaneous or assisted? So let's break that down for us. If we're in AC CMV, assist control, then there's a couple of different types of breath types that we can have there as far as the type of breath that's triggered there. We can have a mandatory breath there, which is based off the respiratory rate. So if I have a rate of 12, the vent's going to give a mandatory breath of every 5 seconds unless I want to breathe higher than that. The other type is assistant. So in AC mode, if I have an assisted breath and I go ahead and trigger that breath, I trigger that breath by either sucking in or deflecting down, and that tells the vent, hey, that patient wants a breath, and the ventilator takes over and does the breath throughout the entire breath cycle, and so that's an assisted breath. The other breath you see there is spontaneous. You get spontaneous breaths either in spontaneous mode or in SIMV. So in SIMV, you get the set rate that you've set. Then if the patient wants to breathe any spontaneous breaths above that set rate, then it's going to be a spontaneous breath. The difference between an assisted breath and a spontaneous breath is that spontaneous breath, they do the whole breath cycle on their own, versus the assisted breath, they just trigger the vent. The vent just says, okay, here's your breath. So our targeted control variable is we're going to use volume or pressure. If volume is our target, then we set a set tidal volume. If pressure is our target, we're going to set a set PIP or inspiratory pressure. And that's based off of lung compliance, things of that nature. So if we have a volume targeted control, then we guarantee that volume, but the vent's going to say, I want to put all that volume in. The only thing that's going to limit that is if we have some sort of pressure release on our alarm setting that says you can't go above this pressure. Otherwise, that vent's going to try and get that volume in there, come heck or high water, to make that happen. Now that might not be great if we have a patient that has a tight lung or a low compliant lung. So we might put them into pressure control. So now we can control that pressure and make sure that the patient doesn't overpressure. But on the flip side, if it's a tight lung, then we don't have any control over how much volume we can get in there before that hits that pressure. So there's give and take to each type of those targeted control variables. Make sure you guys take a look at that and wrap your heads around the pros and cons of volume and pressure targeted control. Also, the timing of the breath delivery within continuous mandatory ventilation. We call it now AC CMV because they can take a breath when they want. In the old days, you could not. Versus intermittent mandatory ventilation, which is now we refer to as SIMV, and then continuous spontaneous ventilation, which is spontaneous mode, where they can certainly breathe on their own when, wherever, and we don't necessarily have a backup rate for them. So mandatory, the ventilator controls the timing, the tidal volume, and or the inspiratory pressure, as I mentioned on the previous slide. Spontaneous, the patient controls the timing and the tidal volume based on the demand of the patient's lung characteristics. So if they're not tired out, we give them a little bit of pressure support there. They're going to control the breath timing and the tidal volume, how big of a breath they want to take throughout whatever breath cycle they want. So they're on their own. Versus assisted has the characteristics of mandatory and spontaneous, but all or part of that breath is generated by the ventilator. So even though the patient says, hey, I want a breath, the vent's still going to drive the breath to that patient based off of what you've set it at. So as I said earlier, If we have target volume as a control variable, that volume is constant based on the patient's lung characteristics. The volume is constant, the pressure is based on those lung characteristics. So as I said earlier, if we have a tight lung and we try and push that volume in, that pressure is going to increase a lot quicker and higher than a nice, elastic, compliant lung. If we have, so some of the advantages of that and why you'll find most hospitals are going to run their patients in volume is we have that specific volume delivery, and that helps us to really target and maintain a specific CO2, especially if they're not breathing spontaneously. The disadvantages are we can get high pressures, and if we're not having our flow and sensitivity settings, then the patient cannot potentially won't tolerate it great. So that's something we really need to watch when we're using volume as a target. As we're using pressure as the control or target, we set that pressure. But again, if we have a tight lung, then we don't get much volume in there, but we do protect the lung from that high pressure. And so that's why it says there we consider as a lung protective strategy is we have a non-compliant lung, a patient with tight lungs, maybe we just have to draw our line in the sand and say, you know, we're going to allow just this much pressure to the lung to protect it. We might not get the tidal volume we want, but patients find that pressure control is quite comfortable for them in spontaneously breathing, because unlike volume where we have to set a set flow and trigger, in pressure control, that flow is a lot more variable and it's really comfortable, and they can pretty much have, you know, the flow that they want or need, and they tend to be more comfortable in pressure control. So the advantages and disadvantages of pressure control: allows a set pressure. We don't have the risk of overdistension. It has a decelerating flow pattern, which tends to help keep the lung open. Disadvantages, though, is if the lung is tight, then we have low volume delivery. And clinicians don't use this as much as volume control. And when lung characteristics deteriorate, as I said earlier, then we have poor tidal volume, and in line with we have decreased minute volume. So how do we time the breath delivery? In CMV, it can be time or patient triggered, because we're going to set that set respiratory rate. In IMV or SIMV, as you know it, the patient's going to get a set number of mandatory breaths, and then if they want to breathe in between there faster, then that's more of a spontaneous breath. And then in continuous spontaneous ventilation or spontaneous mode, all those breaths are spontaneous, and the patient has to trigger all of them. So in these last couple of slides, last 4 or 5 slides, I hope that you spend some time on what I've just kind of explained everything to you. This is really the meat and potatoes of this week, that we understand what our mode and our breath type is within each mode. If you don't understand this, please shoot me an email or something, and let's make sure that you understand that. And it's no big deal if we have to take whatever time you need to make sure you wrap your head around this, because down the road in future classes and in your career and your clinical time, this is all going to be really expected stuff that you need to know. So when we talk about modes of ventilation, it can be confusing because different manufacturers create their own name, which is the same name for other modes. You know, Draeger can have a PRVC versus Puritan Bennett can have a VC plus. Does the same thing, but they call it different stuff. So we talk about CMV-AC. Know that a true CMV, where we lock out the patient, making the ventilator totally insensitive to the patient, one, isn't advisable, and 2, it just doesn't exist anymore. Vents are better than that. So we call it AC, assist control, or AC CMV. Within that, we can have volume targeted or pressure targeted in that AC CMV. and then the intermittent mandatory ventilation, or SIMV. So VCCMV, as I said earlier, all the breaths are mandatory. If a patient triggered, it is called assist, and so that's what we have now is assist control. And patients that are in a true CMV mode, they actually perform more work of breathing because they're trying to breathe not at that set rate than what we're trying to fix. And that's why we don't use CMV anymore. And so when you see CMV, and if you see it on an exam or things of that nature, know that there's also the AC there, AC CMV, where the patient can breathe when they want, and it's an assisted breath. So within ACCMV, we can either set our pressure control, or we can set volume control. Again, if we're in IMV, we also can set either a volume control or a pressure control, as I've described earlier. And then our spontaneous mode, we can set some CPAP there, or PEEP, which we're going to keep on all three different modes, whether it's SIMV, whether it's AC, or whether it's a spontaneous mode. We're going to have some CPAP or some PEEP there all the time to help keep those airways open and keep those alveoli recruited. And then in spontaneous, we can add some additional help, which is called pressure support. So when that patient breathes, that helps take over some of the resistance of the ET tube. And if they are still a little groggy, or have some air resistance, or still have a little work of breathing, we can titrate that up and down and dial into how much help we want to give that patient. So let's say that maybe today we're not looking at extubating, but we want them to do some work. I'll dial in a pressure support on my patient, and so I'm hitting a tidal volume I want them to, but it's still providing them some work. It's just like any muscle. Our muscles want to atrophy. So if we do all the work on the ventilator, those muscles can atrophy because they're not being used. And so it's a good idea for us to, if we can, that's why we talked about early extubation and daily weaning parameters, is we want to get that patient off the vent as fast as we can, because we know if they get too weak and can't ventilate themselves, then they're stuck on the ventilator. Talking additional, we talked about pressure support, some of the additional pressure support settings that you'll learn in your upper classes in your clinical sites is that we can change rise time, and when we terminate the flow on the breath, and really dial it in for those patients to make them comfortable, especially those patients which maybe we're not going to extubate the next couple of days, but we want them comfortable in doing some of their work. We can adjust that breath slope and all of that, which is a little too advanced for what we're starting in right now. And then lastly is APRV, airway pressure release ventilation. It has similar to a BiPAP, but allows for a high and a low level. The patient can spontaneously breathe at that high or at that low level. And there's a couple of ways to do that. Again, an advanced mode of ventilation that when you get into more critical care realms, that's when we'll want to cover that with you. So far tonight, we've talked about indications for our ventilator, and now we've talked about choosing the vent, choosing our initial mode, and then what kind of breath type, whether it's going to be volume or pressure control. So up to this point, we should know our indications, know what the difference is between hypoxic and hypercarbic respiratory failure. Our considerations, if we try non-invasive, what our indications and contraindications are for non-invasive. and then we make that decision to place them on. We've observed and know the signs of respiratory distress or of respiratory failure, and we place them on, and then we determine our mode and our breath type to manage that patient. So now that we've explored that, let's talk about our initial ventilator settings. And this is going to be part of forthcoming discussions and assignments. So make sure that you understand how to do this. So the first thing we're going to do is we need to determine in volume control, we need to determine a tidal volume and a rate to set. And so we want to, best way to estimate is by using ideal body weight. And how we're going to calculate all the ideal body weight is there's a couple of different formulas out here. The text wants you to use this one. But in men, what you're going to do is you're going to take their height in inches minus 60. So if they're 72 inches, and minus that by 60, that'll be 12. So 6 times 12 is 72, and add that to 106. So if we have 72 plus 106, that's going to be 178. And then we're going to divide that by 2.2 so that we can get it in kilos. And so that would be the ideal body weight for a 6-footer. So if we say 178, to make it easy, make the math easy, we say that they're 180 and divide it by 2, and that gives us 90. Now we can say that's our 90 kilos of ideal body weight. The formula I want you to know and learn is 6 to 8 cc's per kilo of ideal body weight. So if we have a 90 kilo patient, and that's their ideal body weight, and we times 9 times 8 is 72, then we have a initial tidal volume of 720 for that particular patient. Women, we're going to do 105 plus 5 times their height minus 60. So it's a little different. This gives you a predicted value for the body weight. And keep in mind that if the patient gains weight, that we have a 6-foot, 500-pound patient, those lungs aren't any bigger. It's based off of height and it's based off of gender. You'll learn that when you get to do a pulmonary function test. Of course, that tidal volume is going to vary on lung pathology. If we think that we have an ARDS patient, we might just set them at 4 to 6 cc's per kilo. But most of your TMC exams are going to take you to 6 to 8 cc's per kilo for most patients. Again, 4 to 6 kilos for the ARDS crowd. When we place them on a ventilator, based on our tidal volume, we also want to consider our mechanical dead space. Remember, dead space is any gas in the circuit or in the airway that doesn't make gas exchange at the alveolar level. And so we have anatomical dead space, which is basically the terminal bronchial up into the lips of the mouth, is all anatomical. And then we can add mechanical dead space, which is the ET tube and the part of the ventilator circuit. All of that gas doesn't ever exchange. It has to be there as a transmission of gas in and out of the airway. But when we set our tidal volume or our breath on our ventilator, we certainly want to set it as such so that we can set that ventilator to overcome all that. If we have a combined mechanical and anatomical dead space of, say, 250, and we don't set a tidal volume high enough over that to adequately ventilate the patient, get their CO2 off, then we're not doing that patient a bit of good. So here's just a couple of examples of setting up potential breath timing, looking at the IU ratio, etc. But just keep in mind that when we set these patients up, we set their tidal volume. We're going to set a respiratory rate because we have a target minute volume to get rid of our CO2. Ideally, if they'll breathe on their own, then that makes our life really easy. but you also need to determine how fast that gas will be delivered. Keep in mind that most adults want flows, and that's the rate of gas flow, or how fast that gas flows is measured in liters per minute. Most adults like 30 to 40 at least liters of flow per minute when they suck in for a breath. But you'll find that when patients are on artificial airways on ventilators, it's higher as 60 to 80. And I've seen post-code patients that are breathing really hard and fast want as high as 100 to 110 liters a minute of flow. Now that's not that a total amount of flow getting to the patient, that's the amount of flow in a minute. So if they're sucking in, that just is how fast that gas is traveling. We also have flow patterns of how that on the waveform enters into the patient. Do we get a really ramp up style of flow, or does it flow in and then level off for a while and then back down, which we call square waveform? Or does it ramp up to a high and then it slowly trickles out? The descending or decelerating flow is typically most comfortable for folks because it mimics normal breathing. If you think that we have a 90 ratio of 1 to 2 or 3, we suck in fast, and then when we exhale, it's passive, so it takes a little longer. And so those ventilators, you can dial in your flow pattern to mimic that. So here we have a rectangular, sinusoidal, ascending ramp, descending ramp, and exponential decay. So these are the popular flow patterns. Most modern ventilators, you're going to dial in a descending ramp. Tends to be most comfortable and most beneficial to the lung. So one thing we want to establish, as I mentioned just a minute ago, is setting that minute ventilation. So when we set that minute ventilation, we want, remember, that's calculated rate times tidal volume, and that's really the name of the game. When I write down a blood gas for my patient report, I always report what the minute volume was on that, and that helps my RTs know this is how much minute volume was being used to hit a target tidal volume of that CO2 on our blood gas. So get used to start talking about minute volume as our number that we use to blow CO2 off. If we need to increase our minute volume, we want to increase our CO2 to blow our CO2 off. If we want to decrease our minute volume, then we want that CO2 to increase. And so that's how that'll work. So our initial ventilator settings, we want to set a baseline PEEP. Most folks start off of about 5 to 8. If they have increased oxygenation need, then we might go up to 10. The magic number that the NBRC wants you to know on your TMC exam is 60. If you're above 60% FiO2, you need to turn your PEEP up. If you're below 60% FiO2, then you can wean your PEEP. We need to determine our tidal volume. We talked about how to set that, and then we want to watch to make sure that we're hitting that proper tidal volume without causing excess pressure. Our initial settings for pressure support ventilation, same deal. If we need to turn up our pressure support to hit that target tidal volume based off our ideal body weight, we can. And also, if we have pressure control ventilation, we want to set up that pressure, that PIP or the inspiratory pressure based off what our vent's doing to hit that target tidal volume. So it's really important that we understand what that ideal body weight is on that patient and what our target tidal volume should be, so that when we make those changes, we expect to know what it needs to be at so we can adequately ventilate our patients. And this is just going over what I was talking about. So we covered a lot tonight. We went fast. Read your chapters, watch the lecture, look at the pictures, and then take a look at some of those tutorials in the media section of Canvas that has some videos and so forth. do your discussions, do your assignments, look at all of that. And if you're having trouble wrapping your head around that, please get a hold of me. Please let me know. It's important that you understand this portion of the course so that we can move on to more things for next week. So I encourage you to do that. Please contact me if you're confused or if you need questions answered. And I am more than happy to help you. This is heavy stuff, but it's fun stuff. It's the essence of our business, and it's the part that I enjoy the most is managing vents on sick patients. And so tonight we talked about indications for that, considerations, things we can try without initiating mechanical ventilation, and then certainly if we need to, what our criteria is, what we're watching for, and then go ahead and placing them on what our initial settings should be. So tonight, after tonight, you should know what modes there are, which is assist control, IMV or SIMV, and then spontaneous, and then our breath types. In assist control and SIMV, there's pressure control and volume control, and then in spontaneous, there's either pressure support and also there's a volume support, which is just a target tidal volume that the vent titrates automatically the pressure support to hit that tidal volume. So know when and where we're going to use those. Obviously, we're going to use assist control more as the initial phase when the patient is sickest. And then when we start to wean them off, then we'll start thinking about spontaneous mode, let them do some network of breathing to keep their muscles strong. Appreciate your time tonight. And like I say, if you have questions, concerns, comments, get a hold of me. Take a look at your discussions and your assignments, and I'll also post some things to help you as well. But look forward to your forthcoming discussion assignments posts. Remember, everything's due Saturday night, and your first main post is due Wednesday night. So I hope you all have a good night, and we'll see you same time, same place next week for the live lecture. Good night.